just a minute. We are preparing for live.
Okay.
It's live.
Okay.
Just a minute.
Right.
So we are already live. So with all your due permission, we are beginning with the session for today.
Yeah, I am ready.
Good afternoon, everyone. This is Batul from IGCP, and I would like to welcome all the viewers who have joined our platform for the better exchange of knowledge that is going to be shared by our keynote speaker, doctor, for today's session. Sir needs no introduction, but it's my pleasure and honor to introduce him at our platform. And he is none other than a very renowned venereologist, Dr. C. Sharath Kumar, sir. Sir is MBBS, MS, PhD in male infertility, FECSM, FPSM, DMRD, DRCOG, DGLS, FCGP, DYN, CUS, FCGP, Principal and Professor and Head of the Department of Reproductive Medicine and Surgery at Mediwave Institute of Medical Sciences, Sayaji Rao Road, Mysore. Consultant sexologist and fertility surgeon at Apollo BGS Hospital, Kuvempunagar, Mysuru, and Neo Priyadarshini Hospital at Vrindavan Extension, Mysuru. With the help of sir, we'll be taking a close look on today's topic. And the topic for today's session is scrotal testicular anatomy function, common disorders and management. Before moving on to today's session, let us have a brief look on what the topic says. There are two major primary disorders affecting the male external reproductive organs. These include penile dysfunction and testicular disorders. Testicular trauma, testicular torsion, testicular cancer, epididymitis, and hypogonadism are among the most common testicular disorders. To know more about this session, we'll be looking forward with sir as he will be giving us a brief introduction and he will be continuing with the topic. Now, without any further delay, I would like to welcome sir at our forum and would like to hand over the session to him for his talk to begin. Sir, over to you.
Yeah, good afternoon, everybody. Thank you very much for nice introduction. I'm so happy to be with all my colleagues of IJCP. We are here to exchange our knowledge, especially in the field of medicine. So whatever the knowledge we exchange, we all get benefit, not only the speaker, also all the listeners. So without wasting any of your precious time, I would directly go to the subject. Today, I'm going to talk to you on scrotal, which includes testis, of course, anatomy, function, and common disorders. I'm not going to touch very uncommon disorders. I'm just going to touch common disorders and their management. So before talking of any other topics, we have to know the basic principles, that is anatomy and physiology. So the chapters which I'm going to cover are introduction to this subject, parts of the male reproductive system, anatomy of scrotum, anatomy of testis and epididymis, common disorders of this scrotum, and diagnosis and management. As you know very well, the parts of the male reproductive system includes the penis, scrotum, testis, epididymis, vas deferens, prostate, seminal vesicles, and bulbourethral glands. Today, I'm going to touch mainly upon the second and third and fourth, that is scrotum, testis. Of course, scrotum includes the testis and testis includes the epididymis. I am going to touch upon scrotum, testis, and epididymis because they are all inseparable parts, both anatomically and physiologically. So, naturally, all the diseases which affect the testis will affect the scrotum, and all the diseases which affects the epididymis affects the testis and scrotum. So, I'm taking all the three together so that we cover everything about the scrotum, testis, and epididymis. As you know very well, scrotum is a fibromuscular cutaneous sac located between the penis and anus. It is a dual chamber formed by an expansion of the perineum. This is how the testis looks and sometimes it will be placed horizontally, sometimes it will placed perpendicularly, sometimes the testis will be obliquely placed. So it differs individually. And embryologically, scrotum is derived from the paired genital swelling. During development, the genital swellings fuse in the midline in the adult This fusion is marked by the scrotal raphe. Scrotum is biologically homologous with labia majora. This is how the scrotum looks. You can see layer by layer. Outside, you can see the skin and the raphe, robust skin. And the first layer, when you remove the skin, you see the cremaster muscles, dartus muscles, and scrotal septum also you can see. And if you dissect deeply in the third layer, in the cross section, you can see testes, epidermis, the lymphatic vessels, autonomic nervous system, spermatic cord, ductus deferens, and plexus of the testicular vein called as pamphiporum plexus. So these are the layers. The contents of the scrotum, all of you know very well that it contains the testis, epidermis, spermatic cord, and muscle fibers located within the scrotum. The dartos muscle is a sheet of smooth muscle situated immediately underneath the skin. It acts to help regulate the temperature of the scrotum by wrinkling the skin. This decreases the surface area, reducing the heat loss. The testis, you know very well, it produces the sperm. Epidermis, you know, it is situated at the head of the testicle. Its function as a storage of reservoir of the sperms. Spermatic cord, a collection of muscles, fibers, vessels, nerves, and ducts. There is vast difference which run to and fro from the testis. That is the spermatic cord. So neurovascular supply, scrotum receives neurovascular supply from the nearby vessels and nerves. This is in contrast to the testes, which carry their vessels, nerves, lymph drainage from the abdomen during their development. So the main difference between the scrotum and testis as far as the blood supply and the nerves and lymphatics is the nerve supply, blood supply, venous drainage, and lymphatic drainage of the scrotum is from the nearby structures, that is perineal structures, whereas the testis, actually they are internal organs of the abdomen. They have descended from the lower abdomen into the scrotum way back when the child was at an infant, that is in the intra-abdominal, intrauterine life itself, that is at the 7th, 8th, 9th month, the testes descend from the abdomen into the scrotum. So while descending, they naturally carry all the vessels, that is the arterial supply, venous drainage, lymphatic drainage, and the nerves from the abdomen. That's why there is difference between the scrotum and the testis as far as the neurovascular supply is concerned. The nerves of the scrotum, cutaneous innervation to the scrotum is supplied via several nerves. That is anterior and anterolateral aspect is supplied by the anterior scrotal nerves derived from the genital branch of the genitofemoral nerve and ilioinguinal nerve. So ilioinguinal nerve and genitofemoral nerve supply the scrotum. The posterior aspect of the scrotum is supplied by the nerves derived from the perineal branch of the pudendal nerve and posterior femoral cutaneous nerve. The importance of knowing these nerves is when we want to do a local surgery by giving local anesthesia, one should be aware from where these nerves are coming so that we can give the nerve block easily. And arterial supply, the scrotum receives arterial supply from anterior and posterior scrotal arteries. Anterior scrotal artery arises from the external pudendal artery, while the posterior is derives from the internal pudendal artery. So friends, note that the arterial supply to the scrotum comes from the pudendal, that is internal pudendal and external pudendal artery. It is slightly different from the scrotum, from the testis, which I am going to talk later on. The venous drainage, the vein follow the same path as the arteries, that is external pudendal veins. Lymphatics also are similar from the scrotum drains to the nearby superficial inguinal nodes. That's why the inguinal nodes get enlarged whenever there is scrotal infection. You can see in the picture how the lymphatics are drained into the superficial inguinal nodes. So coming to the testis and epidermis. So the first thing I covered was the anatomy of the scrotum. Now I am coming to the anatomy of the testis and epidermis. I have taken the anatomy of testis and epidermis together because most of the anatomical features, that is vascular supply, venous drainage, nerve supply, all are almost the same to the testis and epidermis. They are closely placed also. They are paired structures located within the scrotum. Testes are the site of sperm production and hormone synthesis, that is testosterone synthesis. Epidermis has a role of storage of the sperm. Testes are ellipsoid shape. They consist of lobules, each containing seminiferous tubules supported by interstitial tissue. The seminiferous tubules are lined by Sertoli cells. In the interstitial tissue lie the Leydig cells. You can see in the picture the spermatocord, epidermis, testis, and tunica vaginalis, which covers the testis. And this is how the cross-section of the epidermis and testis looks. Epidermis consists of single heavily coiled duct. It can be divided into three parts: the head, body, and the tail. And you can see the cross-section of the testis also. It contains the seminiferous tubules, tunica albuginea, you can see. And all these seminiferous tubules, they conglomerate and form the head of the epidermis. It is a single coiled structure. All these seminiferous tubules open into this coiled structure and they form the body of the epidermis. And later on, it converts into the tail of the epidermis. It's all coiled, single coil structure, single lumen, and ultimately it results in the vas deferens. You can see in the picture. Epidermis consists of head, the most proximal part of the epidermis. It is formed by the efferent tubules of the testis, which transports the sperm from the testis into the epidermis. Body is formed by a heavily coiled duct of the epidermis. Tail is the most distal part of the epidermis. It marks the origin of the vas deferens, which transfers sperm into the prostatic portion of the urethra, ready for the ejaculation. And anatomical position, the testes are located within the scrotum, with the epidermis situated on the posterolateral aspect of the each testis. You can see in the picture, it is posterolateral aspect. Commonly, left testicle lies slightly lower than the right. They are suspended by the abdomen, by the spermatocord. Collection of vessels, nerves, and ducts supply the testes. In the picture, you can see the position of the testis, scrotum, testicles, epidermis. It is situated between the penis and the anus. As I told you earlier, the testes descend from the abdomen. That's why they carry all the vascular and nerve supply from the abdomen. The testes are located in the posterior aspect of the abdominal wall. During embryonic development, they descend down the abdomen and through the inguinal canal to reach the scrotum. That's why we see so many anomalies during this transport. Many times we see undescended testes. The testes will be sometimes they will be low in the lower abdomen, sometimes in the inguinal region, sometimes in the lower inguinal region, sometimes in the inguinoscrotal region, and ultimately in the scrotum. That is why we see lot of hernias and undescended testes because they arise early in the intrauterine life in the abdomen, later on descend through the inguinal canal into the scrotum. So anatomical structure inside the scrotum, testes are covered almost entirely by the tunica vaginalis, a closed sac of parietal peritoneal organ that contains a small amount of viscous fluid. This sac covers the anterior surface and sides of each testis and works like a peritoneal sac, lubricating the surface of the testis and allowing the friction-free movement of the testis. Testicular parenchyma is protected by tunica albuginea, a fibrous capsule that encloses the testis. It penetrates into the parenchyma of each testis with diaphragms, dividing it into so many lobules. So you saw in the picture how it is divided. The tunica albuginea enters into the body of the testis like diaphragms and divides into so many lobules. The testicular function, the most important testicular function is, of course, it is the production of the sperm. And the very important feature of the testis is that it functions best when it lies at a lower temperature than the body. That's why they hang freely. The pampinomorum plexus acts as a heat exchanger, cooling the arterial blood before it reaches the testis. As it travels through the inguinal canal, the pampinomorum plexus condenses into a single testicular vein. So sperm production, you know very well, spermatozoa are produced in the seminiferous tubules, and the developing sperm travels through the tubules, collecting into the rete testis. You can see the rete testis in the center of the testis. And that known as efferent tubules transports the sperm from the rete testis to the epidermis for storage and maturation. In the cross section, you can see very well how these functions. You can see the mediastinum, you can see the rete testis, you can see the lobules separated by the septa. You can see the covering, outer covering, that is tunica vaginalis. And you can also see the mediastinum and how all these ducts are entering into the efferent ductus and later on into the head of the epidermis, and which forms loops. And it is a single lumen, and ultimately it becomes a tile of the epidermis, and ultimately it acts as the final duct, that is ductus deferens, which carries the sperms from the testis into the common ejaculatory duct later on. So coming to the innervation of the testis and epidermis, testis and epidermis receive the innervation from the testicular plexus, a network of nerves derived from the renal and aortic plexus. They are from T12, N1, L2, L3, and also from S1, S2, S3, and S4. You can see both the plexus, how they are supplying the both the testis as well as the epidermis. Pudendal nerve is coming from S2, S3, S4, and the ilioinguinal nerve is coming from L1, L2, L3, and cremaster muscle nerve, that is genitofemoral nerve, is coming from L1, L2, L3. The green one is the genitofemoral nerve, and the left side you can see the brown colored one, ilioinguinal nerve. It is colored just to show you the nerves themselves are not covered. Of course, every one of you know. And the pudendal nerve, which is shown in the blue color, it is coming from the S2, S3, F4. And the blackish color, that is perineal branch of the posterior femoral nerve, cutaneous nerve, is coming from S1, S2, S3. So these are all the main nerves which supply the testis and the epidermis. Vascular supply, the main arterial supply to the testis and epidermis is via the paired testicular arteries, which arise directly from the abdominal wall. So that's why when the testis descend, they carry this artery. They descend down to the abdomen and pass into the scrotum via the inguinal canal contained within the spermatic cord. Testes are also supplied by the branches of the cremastic artery from the inferior epigastric artery and the artery of the vas deferens, that is from the inferior vesical artery. These branches give anastomosis to the main testicular artery. Venous drainage is almost similar to the arterial supply. Venous drainage is achieved via paired testicular veins. They are formed from the pampiniform plexus in the scrotum, a network of veins wrapped around the testicular artery. In the retroperitoneal space of abdomen, the left testicular vein drains into the left renal vein, while the right testicular vein drains directly into the inferior renal cava. Friends, please note the difference between these two. It's usually a multi-choice question in the NEET examination, from where the left testis drains and where the right testis drains. The usual mistakes they do is either they mix or they say both go into the inferior vena cava or both drain into the left and right renal vein. It is not like that. They drain differently. Please note this difference. And what is pampiniform plexus? Pampiniform plexus is a network of veins responsible for the venous drainage of the testis. They wrap around the testicular artery. It has unique configuration, wrapping itself around the testicular artery. You can see in the picture, the blue color ones are the testicular pampiniform veins. They form the pampiniform plexus. And the red one you can see, which is running in the inside, that is the testicular artery. Also in the cross section, you can see the spermatic cord, mystic muscle, testicle, and vas deferens. So friends, have covered the basic anatomy and physiology of scrotum, testis, and epidermis. Now I am coming to the real topic of the day, that is disorders of the scrotum, that is which includes, of course, the testis and the epidermis. So first I will take up the signs and symptoms of the scrotal disorders, because the person who comes to us doesn't know where the testis is, where the epidermis is. He simply tells everything as scrotum. For him, scrotum is itself an organ, and the patient usually comes with pain in the scrotum or testicles, a lump or swelling of the testicle, discoloration of the skin of the scrotum, an abnormal feeling of warmth in the area. He may also complain of blood in the semen, discoloration of the semen. He can also come with a complaint of blood or pus in the urine, discoloration of the urine, pain in the groin, pain in the lower abdomen, sometimes fever, and sometimes difficulty in micturition, frequency of micturition. So friends, these are all the signs and symptoms which the patient presents to us when he comes with scrotal problems. So there may be tender or swollen, hardened testicles, tender, swollen, hardened epidermis, swelling of the scrotum. There may be nausea and vomiting also if there is severe infection. And also patient with chronic problems can come with the loss of libido, erectile dysfunction, premature ejaculation, loss of desire also. And they can also come with the low semen output and low sperm count. And ultimately, even they may present with a sign and symptom of infertility, that is male infertility. So friends, these are all some of the signs and symptoms which the patient presents to us with a history of the scrotal disorder. So commonest disorder I'm going to touch because I'm not going to touch on common disorders because they are out of the topic here. The common disorders of the scrotum are, the first and foremost is the benign masses. That includes the sphenoidocele, hydrocele, hematocele. The second one, commonest, of course, in our country are the infections, which includes orchitis, the epidermitis, and epidermoorchitis. And the third one, of course, in the youngsters is testicular torsion. Then, of course, we have varicocele, hernias, malignancy. So these are the common disorders which we come across in the day-to-day life of our clinical practice. I'm going to touch each one of them, how they present, and of course, I will let you know the management also. So scrotal mass needs to be examined even if there is no pain or having other symptoms. Many times I have seen myself in my clinical practice, patients coming out with huge hydrocele, with huge mass, with hernias, where the scrotal mass is there. Since there is no pain, there is no problem, they never present. They come only when they have some problem. So there are several scrotal masses which don't have pain, and they wait till it becomes so large and uncomfortable. Then only they come to you for the examination. But of course, scrotal masses could be cancerous or caused by another condition that affects testicular function and health. So one should be careful, and one should take seriously any mass, even if it is painless, because later on it can either get itself converted into a cancer, or it may affect the testicular function, resulting in infertility, and also can create health problems. Scrotal sac is a very distensible and will enlarge in response to the size of the contents. I have seen huge hydroceles, huge masses, huge hernias, which is almost physically one cannot carry. Till then, they don't come to the doctor. So because the scrotal sac is so much distensible that it can take volumes, that is liters of hydrocele, and about 100 and 200 cc volume of the hernias, so, and hematomas and cysts, benign cysts. That's why many times the patient comes very late because there is no other problem. So examination, of course, I need not tell to the doctors how to examine the testis. It's very important to know this, the size, shape, and position of the testis, and gently roll the testicle between your thumb and the fingers. Look or feel any change in the testicle. It includes look for the lumps, smooth bumps, or new changes in the size, shape, and consistency of the testicle, and also assess the size of the testis. And what are the investigations to be done for the patient? So trans-elimination test, for if there's a tumor, so that we can rule out the hydrocele. Ultrasound scanning, urine test, routine blood test, and if necessary, CT scan or MRI scan, and when necessary, fine needle aspiration cytology and biopsy of the testis. So these are some of the basic investigations to be done for the scrotum for ruling out the major issues whenever the patient presents with signs and symptoms of testicular or scrotal disorder. So coming to the masses, that is testicular mass, First, I will take up benign mass, which is non-cancerous mass of the scrotum. The three commonest benign mass of the scrotum are hematocele, hydrocele, and spermatocele. Let us take up the hydrocele first. Hydrocele refers to a fluid collection surrounding the testicle, and usually it is benign. If it is large enough, it can cause pain or pressure. You can see the hydrocele, which is surrounding the testis. In fact, tunica vaginalis is a potential space. It is nothing but extension of the parietal and visceral peritoneum from the abdomen. That's why it can easily accommodate large quantities of fluid that is called as hydrocele. Usually, it will be quite clear. In the transelimination test, you can see through and through the illumination passes through the hydrocele. That's why transelimination test is a basic examination whenever we see a mass in the testis, and that is in the scrotum. If the transelimination phase, that is if the light doesn't pass through and through the mass, then it is not hydrocele. It could be something else. The congenital form, there are two types of hydroceles, congenital and adult form. Congenital form is mostly common due to the failure of the processus vaginalis to close. That is, I told you earlier, it is extension of the peritoneum, and the sac, once it is formed, it should close. If it doesn't close, then the fluid from the peritoneum can directly enter the tunica vaginalis and form the hydrocele. In fact, when there is a peritoneal when there is ascites, fluid easily comes to the tunica and forms the hydrocele also. Adult hydrocele is often associated with inflammation or trauma and rarely with testicular tumors. So, two types of hydroceles are there, the congenital form and the adult hydrocele. The next mass, which is benign, is the hematocele. Hematocele is collection of blood in the tunica vaginalis. Instead of clear fluid, it is collection of the blood. So when we do the transelimination test, the light fails to travel through and through the tunica, and it will be opaque. Then we know that it is not clear fluid, that it is not hydrocele, it is hematocele. It can be distinguished from hydrocele by transelimination, where light is applied to the testicular swelling. Due to dense nature of the blood, light is unable to pass through. The next benign tumor of the scrotum is hematoma. Hematoma may develop in the scrotum as a result of scrotal surgery or trauma in the genital region. The result is swelling, that is edema, and discoloration of the scrotal skin. You can see in the picture how the scrotal skin of a fairly colored person has become dark and brown. Sorry. Occasionally, the origin of bleeding may not arise from the scrotal content, that is spermatic cord and testis, but from the basal part of the penile urethra, that is bulbar urethra, as in the straddle injuries, directly perineal trauma like when falling into a bicycle crossbar. So, most of the hematomas are due to injuries, cricket ball injury, or crossbar bar injury of the bicycle or the motorbike, or any direct hitting into the perineal region. The third most important benign tumor of the scrotum is the spermatocele. Spermatocele usually causes no signs and symptoms, and it might remain stable in size. If it becomes large enough, however, you may feel the pain or discomfort in the affected testicle, heaviness in the testicle with the spermatocele. It is usually a collection of the sperm. In this one, you can see the epididymis, spermatocele, testis, and also in the cross section, you can see how a normal testis and epididymis looks and how a spermatocele looks. So the next scrotal disorders are the infections. The infections may be orchitis or epididymitis or epididymoarchitis. Epididymitis is the inflammation of the epididymis, usually caused by bacterial or viral infection. You can see in the picture the normal epididymis, how it is looking, and the inflamed, swollen epididymis, how it is looking. Epididyma occurs when the epididymis becomes inflamed or sometimes it is sexually transmitted infections. So any epididymal infection or orchitis or epididymal orchitis, the first and foremost thing you have to do is rule out the sexually transmitted infections. More often, epididymis comes from the injury, buildup of pressure such as after a vasectomy or from urine backwashing into the tubers during heavy lifting or straining. Epididymis can cause symptoms ranging from mild irritation to severe testicular pain, swelling, and fever. So most of the infections, that is epididymitis, orchitis, or epididymarchitis, can give rise to general illness also, which includes, of course, the fever, swelling, and pain. Orchitis is limited to the testis. Orchitis is inflammation of one or both the testes caused by infection or mumps. It can also be caused by any sexually transmitted diseases, including the gonorrhea and chlamydia. From outside, it looks red, swollen, either both the testes may be involved or one single testis may be involved. Epididymitis is nothing but when both the organs are infected, that is both testis and the epididymis. This infection from every testicle both causing inflammation and pain. And of course, treatment I will come to later on. The next commonest disorder of the scrotum which we come across in our clinical practice is varicocele. Varicocele is dilatation of the veins above the testicle and is usually harmless. That is the dilatation of the pamphiforum plexus. If you have bulge over your testicle, especially when you are standing or bearing down, you should have, get it examined. It can cause pain or it can cause oligospermia, resulting in sometimes infertility also. Varicocele is quite common in general population. Its prevalence is estimated to be about 15 to 25%. That means usually subclinical varicocele, that's grade 1 or grade 2, will be there in almost everybody, and it should not be taken seriously. Many times these varicocele is diagnosed incidentally when the testicular scanning is done for some other purposes. That should not be taken seriously unless it is grade 4. And also all male infertility patients who undergo tests usually will have varicocele grade 1 or grade 2. That is quite normal because general population also contain 15 to 25% of the men having varicocele. And directly blaming this varicocele grade 1 and grade 2 in an infertile male person creates problems because the person thinks that getting rid of this varicocele by surgery, he will become potent. No, it is not true. The oligospermia may not be due to this varicocele unless the grade 4 varicocele is there. That in itself is the cause for the oligospermia. Then it will be helpful for the person to get the surgery done. Doing a varicocelectomy for a subclinical varicocele, that is grade 1 or grade 2, will not help the person who is having oligospermia. The cause of oligospermia may be entirely different, not the varicocele. So blaming the varicocele for oligospermia and doing a surgery for it, the results may not be good. And a lot of counseling has to be done and told the patient that this varicocele may be an incidental finding and doing varicocelectomy may or may not help you. So in spite of that, if the patient agrees, then we have to go ahead with the surgery. This congenital situation should not be considered a disease. Sperm quality is affected only in small portions of the patients. So only about 30 to 40% of the patients with oligospermia get benefit out of varicocelectomy. That is the two when the varicocele is of grade 3 or grade 4. The next common disorder of the scrotum is the torsion of the testis. Torsion means twisting of a testicle. And when testicular torsion occurs, twisting kinks like a garden hose and blocks the blood vessels to the testicle. It is usually unilateral. And certain men have developmental problem that makes them susceptible to testicular torsion. Maybe short spermatic cord. Although testicular torsion is rare, it is an emergency. Sudden testicular pain demands an immediate trip to the emergency room. If treatment is delayed, testicle can die. Torsion is most common during puberty between the age of 10 and 15. So it is important to let young teens know that any pain, it should be reported even if they are embracing to them. So testicular torsion is an youngster's problem. One should know about it. The next common disorder which we come in the scrotum is the hernias. Hernias are sometimes mistaken for testicular disease because it is occurring in the scrotum. When lower part of the abdominal wall muscles are weak, the part of the intestine can pulse through it. And when the intestine pushes into the scrotum, it is called inguinal hernia. All the scrotum swells. It can appear to be a testicular problem. So in the picture, you can see how the abdominal content, that is the intestine, is entering into the scrotum, causing the hernia, that is inguinoscrotal hernia. Many times these inguinoscrotal hernias will be temporary. Many times they pass back into the abdominal cavity when the person lies down. And many times they will be wandering hernias, that is they transfer between the abdomen and the scrotum. And the person himself can push back the hernia into the abdomen. But once it is fixed, the problem of strangulation of the hernia can occur. That's why all inguinal hernias had to be repaired, because to prevent the further complication of strangulation of the hernia. The next, of course, the deadly disease of the scrotum are the testicular cancers. Testicular cancer is one of the most curable cancers. Even after it has spread, testicular cancer is usually curable. The best chance of cure are when the cancer is detected in the early stage. In the picture, you can see the mass which is arising from the testis, that is a tumor, and you can see the epididymis vas deferens. Like any cancer, testicular cancer happens when the cells in the testicle develop mutation that cause them to misbehave. They don't follow the natural law of multiplication. They start multiplying at their own pace. That is called as the misbehavior. The cells may multiply recklessly and invade the areas where they don't belong. In testicular cancer, this process usually creates a slow-growing, painless lump or firmness in one testicle. In most cases, the men themselves discover it as an early stage by self-examination. 97% of testicular tumors are from germinal in origin, with seminoma being the most common, followed by embryonal cell carcinoma, teratoma, and choriocarcinoma. So friends, these are the four commonest tumors of the testis, that is the seminoma, embryonal cell carcinoma, teratoma, and choriocarcinoma. So now I have finished almost the anatomy, physiology of the scrotum and testis, and the signs and symptoms of the testicular disorders, and the common testicular disorders, which included, of course, infections, hematoma, hamartoma, varicocele, and hernias, and hydrocele, and cancers. Now I am taking up the last chapter of today's lecture, that is management of the scrotal mass and scrotal disorders. The first and foremost is the infections, management of infections. All of you know we can manage the infection once we know what bacteria or virus has infected. Scrotal masses caused by bacterial infection, as is usually the case with epididymitis, are treated with antibiotics. Sometimes antiviral treatment may have to be given. Viral infections causing epididymis or otitis are usually treated with rest, ice pack, pain relief for the medication, and of course, appropriate antibiotic. Anti-inflammatory drugs may also be added so that the inflammation comes down. So management of the infection is conservative with antibiotic and anti-inflammatory drugs. Management of epididymitis is usually treated successfully with antibiotics and anti-inflammatory drugs. And bed rest is very important. Pain medications using athletic support and ice packs to the scrotum may help to decrease the severe cases. Pain can resolve very slowly, sometimes taking weeks or months also. So coming to the torsion, testicular torsion, management of the testicular torsion. Testicular torsion is a true medical emergency, one should know. If it is delayed, the testis may die. That's why the patient has to be hurried up into the operation theater. If caught in time, the affected testis can be saved. Emergency surgery is usually required to untwist the testicle and to prevent it from happening again. During the surgery, the other side is usually fixed as the condition tends to be bilateral. Surgery is required to correct the testicular torsion. In some instances, one might be able to untwist the testicle by pushing on the scrotum manual deterioration, but you still need surgery to prevent torsion from occurring again. Surgery of testicular torsion is usually done under general anesthesia. Coming to the management of the varicoses, varicocele usually don't require treatment. Earlier, I told you, grade 1 and grade 2 varicoses are quite common. They are subclinical in nature. Even if you do the scanning of the general population, 10 to 12, 15 to 25% of men have got either unilateral or bilateral varicocele. And unless they are symptomatic, they don't require any treatment. And even if treatment is given, whatever the problems they might have come, that may not go. That's why counseling is very important to do varicocelectomy for any patient. There are no drugs to treat or prevent the varicocele, but if there is pain, painkillers like acetaminophen or ibuprofen may help with to relieve the pain. Even simple paracetamol will also help. When needed, surgery is the main form of treatment. Embolization, that is briefly blocking the vein, is a non-surgical treatment that is being developed, or the final treatment. This is, of course, varicocelectomy, either unilateral or bilateral, depending upon the situation. Occasionally, however, varicocele can impair infertility. So, if the patient comes with oligostenospermia or oligospermia, and if there is incidentally varicocele also, and if the varicocele is grade 3 or grade 4, the varicocelectomy may help the person, and this percentage of success is 30 to 40% of the varicocelectomy patient getting better with the better count. Can cause mild to moderate pain, but for men with varicoceles, the impaired for infertility, microsurgery to tie off the dilated veins of the varicocele is effective, and varicoceles can also be corrected without surgery by injecting tiny coil into the abdominal vein. So there are several methods of the surgery for the varicoceles. And coming to the management of the hydrocele, there are no medications available to treat the hydrocele. Hydrocele usually does not need to be surgically repaired unless it is very large and it is causing a lot of pain and discomfort to the patient, unless the testis is fully pushed or it is getting atrophied. Hydrocele typically goes away on its own within 6 to 12 months of the age. Needle aspiration and sclerotherapy can be attempted. Needle aspiration and sclerotherapy is injecting tetracycline into the tunica vaginalis after removing the hydrocele. The disadvantage of needle aspiration and sclerotherapy is that recurrence chances of hydrocele is about 5%, and sometimes severe pain can occur after injecting the sclerotherapeutic agent, because it may enter not to the tunica vaginalis, it may directly enter into the testicular mass, and it can cause severe pain, and sometimes it can even give a shock to the patient. So one should be careful in needle aspiration and sclerotherapy because of the deadly complication of the shock. If hydrocele does not revolve on its own, then it needs to be surgically repaired, because if there is recurrence of hydrocele after needle aspiration, then also it requires the final surgery. The surgery is nothing but removing the fluid and averting the tunica vaginalis so that it will not recur again. The next one is the management of the spermatocele. The surgeon makes an incision into the scrotum and separates the spermatocele from the epidermis. Surgically, they apply the ice pack for 2 or 3 days. That is non-surgical treatment. Oral pain medication for 2 or 3 days. Return for follow-up examination between 1 to 3 weeks after the surgery. That is for the non-surgical treatment. Coming to the management of the tumors, there is malignant tumors. Testicular cancer is treated according to the type of cancer and how far it has spread. So we have to grade the cancer just like any other cancer, grade 1, grade 2, grade 3, grade 4. Grade 1 is limited inside the testis, grade 2 just outside the testis, grade 3 outside the spreading the scrotum, grade 4 distant organs, that is secondary spread, that is the grade 4 testicular cancer. Cancer that has not spread from the testicle can be cured by orchidectomy, the surgery to remove the testicle. So orchidectomy is the best treatment for a person who comes with testicular tumor grade 1 or up to grade 2 also. If it has spread outside the testicular cancer treatment may include surgery to remove the abdominal lymph nodes, chemotherapy, radiation therapy, or combination of 2 or more of these things. So the treatment of the malignant tumors depends upon the grade of the cancer, grade 1, grade 2, grade 3, grade 4, and how far it has spread, whether the scrotum is affected, whether the inguinal nodes have already been affected. So depending upon all these factors, one may have to go for the orchidectomy followed by chemotherapy, radiation therapy, and combination of the 2 or 3. So chemotherapy, radiotherapy, and surgery are the 3 main treatments of the cancer. You can see in the picture, orchidectomy, that is removal of the testicle, that is the first line of treatment. The second line is chemotherapy, third line is radiotherapy, and the recent treatments of stem cell transplantation, lymph node block dissection can also be tried. Treatment plan will depend on the type of the testicular cancer, whether it is a seminoma or a non-seminoma. Coming to the hernias, the only way to effectively treat hernia is through surgical repair. And of course, the mesh has to be put. Whether you need a surgery depends on the size of the hernia and severity of the symptoms. Simple monitor of your hernia for possible complications. This approach is called as the wait and watch the approach. So if the hernia is quite small and if there is no pain, one can just leave it, keep watching. But if one is causing discomfort, then the hernia repair has to be done. The deadly complication of the hernias, of any hernia, is the torsion of the hernia, that is strangulation of the hernia. Hernial sac may twist on its own, causing the strangulation. Strangulation of an hernia requires immediate emergency surgery. So all the hernia patients must be told that if any torsion occurs or twisting of the hernia occurs or strangulation of the hernia occurs, immediately that person has to rush into the hospital to prevent the further complications of the strangulation of the hernia. Coming to the management of the hematocele, as I told you earlier, hematocele is nothing but a collection of the blood. It goes away on its own. Even if they rupture, they can clear up without surgery. Sometimes surgical removal is necessary and is done by laparoscopy, a fairly non-invasive procedure that requires minimal scarring and recovery time. You can see in the picture a hematocele wrapped with hernial sac and the spermatic cord. So friends, this afternoon I have covered the scrotum as a whole, the contents of the scrotum, that is testis and epididymis, and clinical examination of the testis, scrotum, self-examination of testis and the scrotum, and I have touched upon the anatomy and physiology of the basic scrotum and testis and the epididymis, and also I have touched upon the disorders, how to examine them, what are the tests required, and the basic management of these all these disorders, that is hematoma, hydrocele, varicocele, tumors, benign tumors, and malignant tumors, and hernias. So, friends, we have to take care of the testes. We have to tell the patient to take care of their own testes. And these are the carry-home messages, tips for the healthy testes. Do a monthly testicular self-examination. Roll each testicle around in your own scrotum during the using your fingers. Bath regularly. Take a shower bath every day to keep your entire genital area clean. Wear loose, comfortable clothing. Wear protection whenever you have sex, that is to prevent sexually transmitted diseases. Self-examination and regular health checkup of the scrotum are important for prompt recognition, diagnosis, and treatment of these scrotal masses. Especially, as I told you earlier, most of the scrotal disorders, though they look benign, though they are harmless, though they are painless, they can create complications later on. And infections, they have to be taken care by proper antibiotics. Hydrocele, varicocele, they require no surgery, immediate surgery. But if they have given rise to complications, they have to be treated. Hematoma can be left alone to resolve on itself. And varicoceles, no adherent aggressive treatment is required as far as the surgery is concerned. Cancers, of course, they need to be immediately attended, and any tumor, it has to be seen as a potential cancerous tissue later on and has to be treated aggressively with removal of the tumor, archirectomy, so that it won't spread beyond the testis, and treat appropriately with chemotherapy as well as radiation therapy when it has gone beyond the stage 3 or stage 4. And other scrotal disorders, if the patient has come along with the infertility, before advocating the varicocele surgery, look into other possibilities of causes of oligospermia so that inadvertently we don't remove the varicocele and land up in problem, because that may not give the results which the patient has come for expecting the oligostenospermia to be treated. So friends, that's all for today. I hope my talk was useful to you. I sincerely thank the IJCP authorities for giving me an opportunity to share my knowledge about this with you. And if there are any questions, you are most welcome to please ask. And I would like to tell you that this is not a comprehensive talk on the scrotal disorders. I just touched upon the common disorders which I come across in my day-to-day life as an infertility surgeon and a sexologist. So thank you once again. Have an enjoyable evening. So over to Batul for further deliberations and to pass on the questions if there are any.
Thank you so much, sir. Thank you for such wonderful insights on the topic that you have shared in. I really hope that all the viewers must have get the benefit that they were here for with your the wonderful knowledge and insights that you have shared upon the topic. So thank you so much for that. And we have received few questions, sir. With all your due permission, I would like to put it across to you.
Sure, sure, sure.
The first question is, what causes contralateral disease in testicular torsion?
Yeah, the testicular torsion is usually one side only. But once the torsion occurs, the pain radiates to the other side also. And as I told you earlier, the cause of the testicular torsion is because the spermatic cord may be short and it may easily twist on itself. And that may affect the other testis also. That's why when we do reversal of the torsion of one testis, the other testis has to be fixed. That is, we have to stitch into the side wall of the scrotum so that later on the patient doesn't come back with torsion of the opposite testis. That's why contralateral testis has to be fixed in case of a torsion of one testis. Rarely we see bilateral torsion of the testis. I have not seen, of course.
Thank you so much, sir, for answering this question. We'll move to the next question that we have received. And the question is, what are the impacts of COVID-19 on male fertility?
A wonderful question. So most of the times, even just a few days back, I saw one patient and directly blamed the COVID for his erectile dysfunction. So anything and everything happens after the COVID, that is post-COVID. And I asked him whether he had the COVID. He said no. So he is blaming the COVID for his erectile dysfunction, though himself he had not undergone the COVID. I said, yes, you have the post-COVID symptom, that is post-COVID psychological effect. The COVID has affected so much the society that the psychological trauma as we are unable to come out. Though COVID may not have directly affected any of our organs, it has affected our mind and brain. And post-COVID psychological impact may cause any disease, including the infertility. And patient usually tries to blame the COVID for whatever happens to them after the COVID era. So it is purely psychological in origin. There is absolutely no somatic origin. And if the person has suffered COVID, and if it has really gone into the COVID, and if it has damaged any organ, then of course we can agree that this is a post-COVID infection or post-COVID tumor or etc. But unless otherwise proved, it should be taken as only post-COVID psychological trauma, nothing else.
Thank you so much, sir, for answering this question. We'll move to the next question. And the question is, what kind of screening is available for testicular cancer, and at what age should people start being screened?
Yeah, the best is self-examination of the testes. Keep examining the testes when you take a bath. If you observe any change in the texture of the testis, that is the size, shape, and position, and if it is tender and if it is getting enlarged, then immediately rush into the doctor. And doctor, of course, will examine the testis and see whether both the testis size, shape, and positions are normal. And if he gets any doubt, immediately he will refer to the ultrasound scanning. Color Doppler of the scrotum is the best screening test for the ruling out the scrotal mass and ruling out the benign or malignant nature of the tumor. So the best screening test is self-examination. The second level is doctor examination. Third level of screening is the color Doppler scrotum. And of course, the last one is the FNAC. I don't think FNAC may be required because by these three, we can fix most of the lesions of the scrotum.
Thank you so much, sir, for answering this question. We will move to the next question. And the question is, what are some of the risk factors for testicular cancer? And are there any lifestyle or diet changes that can lower someone's risk?
A wonderful question. As it is, the risk factors of the testicular masses are very few. One, of course, is exposure to the toxic chemicals who work in the paint industries, who work in the industries where there is a lot of smoke, and truck drivers who wear a lot of tight dress and will be sitting in front of the engine for hours together with a lot of heat, which increases the temperature of the testes. So these are some of the, and smoking, of course, these are some of the predisposing factors for the testicular masses. And injury, of course, youngsters, cricket ball injuries, who play cricket without putting the lifeguard, and those who go by bicycle for hours together and suddenly put the brake and get into the jam into the crossbar of the cycle. So these are some of the predisposing risk factors for the scrotal injuries, scrotal mass, and scrotal tumors. Other than this, the risk factors are very little, unlike other organs. And of course, general risk factors which are applicable to all other diseases do apply to the testis and scrotum also. And the next risk factor is multiple partners, that is exposing oneself into the various types of sexually transmitted diseases, including the gonorrhea and HIV. And another risk factor is the viral infections, especially in the childhood, that is mumps, which can result in testicular mass and ultimately even testicular atrophy. So these are some of the risk factors for scrotal disorders.
Thank you so much, sir. Since your topic and your talk was so emphasizing to all the viewers, we are not, they're not stopping us to send their questions. We are still receiving questions.
You can, as long as your time is there, I am.
Yeah, so we have received another question, and the question is, what is bell clapper deformity and how is it related to testicular torsion?
I am sorry, I'm unable to answer. I will refer it and I will come back to you. And please send an email to me. I will answer it later on.
All right, all right. So thank you so much, sir. We cannot see any other questions as of now from the participants. So with all your due permission, we would like to conclude the session here for today until next time. But before that, I would like to thank you. And at the outset, I would also like to thank all the viewers for taking out their valuable time and for being here at our platform and being so attentive at our platform. So thank you so much to all the viewers. And I would also like to thank you, sir, for taking out your valuable time and for being here at our platform and sharing such wonderful insights with the viewers all across the globe. So thank you so much for that, sir.
Yeah, thank you, Batul. Thank you, Nishchita, for continuously calling me and fixing up the time and date and venue and also the topic of the day. And I'm so happy to be associated with IJC people. That gives me a lot of insight to prepare myself. And when I prepare myself, I would have learned more than the others. Thank you, all the doctors, for patiently listening to me. Hope to see you again in my next lecture. Thank you.
Thank you so much, sir. Thank you. So with all your due permission, we are concluding the session here for today.